We're ready. We're live. Let's do it. All right, cool. I got Dr. Frank McCormick here from University Ortho. Wanted to welcome you to the podcast, Legally Exhausted.
Thank you, Abe. Good to be
We've
here.
been talking for an hour because Dennis is behind time.
That's my fault.
Yes, you deserve that. So we were chit-chatting. Obviously, we want to talk about you and your practice. Can you tell us I always find it easy to talk about extremities, but like what body parts specifically? Shoulders, knees, hips. What can you tell the viewers?
You know, for me, as in our University Orthopedics, they would need an orthopedic surgeon that specializes in things outside of spine, right? Because that's been the major impetus for them. For me, I'm sports medicine orthopedic trained, which basically we manage the musculoskeletal system, which means bones, tendons, ligaments, cartilage, muscles, right? Or sometimes even skin. And so for me, extremities is kind of a catch-all saying, hey, we got you. If you have an injury, we're able to manage it. But specifically for me, I'm a specialist in shoulder, hip, and knee. Okay. And a lot of that really is a couple of things. Is one, the background in sports medicine, because if you think those where athletes are getting injured, those are the majority of the athletes getting hurt, which means that's kind of pushed our treatment options in terms of our cutting edge techniques. And we have arthroscopic interventions. So, you know, when we advance the treatment of the shoulder and the hip and the knee, most recently the knee, we can look inside with a camera now, which gives us a lot more leeway to optimize patients' injuries and get them back to what they want to do. And then even with the technology, hip arthroscopy, when I was training, was something that was barely done. It was just done at unique places, such as, I trained at Harvard, so there's a few surgeons doing that, and even that was the cutting edge. Now it's almost like community standard of care, so it's so much easier to do, and that's just in an area of 10 years or so.
And so knees, what kind of procedures do you do for knees? You do knee scopes. What else do you guys do?
Yeah,
what do you do?
So essentially anything that the knee needs, right? And so we're kind of soup to nuts. I'm happy to manage the non-operative stuff. As a sports medicine guy, I have a lot of programs to get athletes back, and so many times you're just minding your own business. You tweak your knee and your knee hurts, but you want to go spin moves or like do those kinds of things. I can get you back because I have that athletic performance and the experience of treating the pros, how to get them back to the highest level that they need to compete, in the Major League Baseball or NBA or NFL, those kinds of things. But frankly, a lot of my guys just need to get back to work, right? And so that's easy. But I think in terms of the different procedures, one thing I'm excited about is technology is changing, and we're kind of trying to advance with that. Certainly after COVID, we're out of the hospitals. The hospitals are not the place where orthopedics want to be. We're at surgery centers or we're at office-based procedures to kind of minimize the risk. Like all my complications are at the hospital because the hospital has, bugs, resources. You're there because you're sick. So if we can do it in the hospital or the surgery center or even in the office, you're back to work. You're not missing any time. Like a lot of the athletes, now they have a new needle arthroscopy, so you can, like the size of a needle that has a camera on the end of it, so you can actually do procedures with no downtime.
That's like the it's like the MRI through the cam, though. It's just a cam.
Better yet, it's not me looking at it through the camera, so we can visualize it, and the patients can stay awake and see about it, or we can turn the fluid on, and even kind of like if there's any cartilage damage or meniscus tear, we can address it right away with no downtime. So that's what a lot of pros are getting. I know that certainly the Patriots were doing that for their assessments, and the guys wouldn't have any downtime. They do it all in the office, and that people wouldn't have to know. And I think certainly, like if you have a meniscal tear and you're at that high level, don't want to miss work, that's certainly an option for you. Or then you don't have to undergo a full surgery and the risk of that. So what's the recovery time? It's minimal because you're awake. It's like just getting your teeth pulled. And then then it goes back to the the whole cartilage options. What I usually see is patients will fall, they'll be playing soccer, twist their knee, or even getting in a car accident with a direct injury to their cartilage. And so I have that cartilage training that I did after my final training. I went overseas to kind of learn what is out there, and then try to bring it back here to the U.S. And we got some pretty impressive options in terms of keeping knees healthy. Oftentimes I'll say if you went to a dentist and said, all right, well, I did an examination. Your teeth is hurting you. You have a cavity, but we don't really have great treatment options, so we're just going to wait till it gets worse, and then we'll pull it when it's ready, right? And so orthopedics have been saying that a long time with the knee replacement, because knee replacement was so successful that they'd say, okay, we don't have anything better. This is what you need, but you have to wait. You're still in pain. I'm like, that doesn't work anymore. And so what we're finding is that the knee needs a healthy joint, as we're kind of considering like an organ. So it has to be like taken care of, healthy, and if you don't take care of it, like your liver, then it's going to start to fail on you. But then that's not really the long-term solution. Just let it fail and replace it. And so now we're actually kind of getting smarter with the cells, treatment options in terms of physiological recovery parameters, managing the kinematics, and doing higher level therapy, but also adding the medications in terms of the therapy. The PRP, and even if you have a focal defect, like if you have a cavity, you fill the defect, right? And so we certainly have those options now for cavities in the knee, but you have to look for it. It makes it a whole heck of a lot easier now that you have, because MRIs are about 70% accurate for this, which means like 1 in 4 are getting missed. We don't know. And so then they're like, I'm still in miserable pain. Nobody can tell me why. Then you have to do an operation on them and risk it. And so now we're excited because you don't necessarily need that operation. You can diagnose at the bedside now, or even
with this
treat.
arthroscopic camera.
Yeah.
Okay.
Mm-hmm.
I forget what it's called, but it's obviously not an MRI, but it was like the MRI killer. Like they're saying it's going to put MRI out of business.
Yep. Mm-hmm.
Yeah.
And there's even evolving models on that. I've been doing it for 10 years, but now the technology is so advanced that actually you can do the same thing in the office that you can do in the surgery center. So there's no, detriment of care. It used to be that you just have to peek and look and see, but now it's actually, you're doing this. You actually have the same tools you would use in the surgery center now in the office, but without the risk to the patient.
Mm-hmm. Wow. Okay. And that's interesting. I didn't know. You're saying a lot of injuries are missed on the MRI. Is that because of the quality of the magnet, or just inherent with MRI in general?
I think MRI lie. Like the MRI is pretty accurate at a lot of things. So, even the meniscus is not as accurate as a physical examination. So sometimes we have an over-reliance on technology to say, okay, what does the MRI show? Well, the MRI helps us in terms of put the complete picture. But many times, there's a history about what's going on. Where's the pain? How bad is the pain? When does the pain come on? And then also, too, the physical examination. And so actually going back to the biceps, what we found is that, MRIs don't show that, right? And so it's actually they're starting to pick up on it because we're getting smarter and recognizing. But nonetheless, is that we looked in terms of the physical examination, and there's, specificity and sensitivity, the accuracy of physical exams, right? Which is pretty important because in theory, that's an important part of the medical diagnosis. So what we did is we did a study and said, okay, what are the higher quality studies out there that would help us diagnose the biceps? And we found that actually if you do 1, it's pretty good, but if you do 2, even better. Kind of makes sense, right? Because if 1 is better than 2, but actually if you add 3, it just creates enough chaos that it's actually no longer valuable. So you should do 1 or 2 together, and if both are positive, then what's your accuracy, especially in certain situations, right? And so we actually found that by doing those examinations, which were way more accurate than the MRI. Right? And then so the gold standard is actually looking at it. And as a surgeon, many times I'll have to confirm my diagnosis to make sure we're right before we actually execute the surgery. But this is going back to, the actual physical examination is sometimes more accurate than the MRI, specifically with the biceps and also with the cartilage issues. It's pretty good if you're going to, evaluate for cancer. But that's not what me as a sports medicine doctor is looking. So I oftentimes will get MRIs just to make sure we're not missing cancer. There's that 1 in 1,000 that I've caught, right? And so that's a huge value if you can find cancer in somebody that you think has a meniscal tear, which happens. Or for me, I remember a guy that thought he had a rotator cuff tear. We found it's a huge tumor. Fantastic, that saves it. But the MRI is not there to substitute for me in terms of the examination and the history. It's an aid for that. And then now bring in this new technology for the joints where, patients at the bedside, rather than giving them an injection, we actually say, all right, let's take a look inside, see what's going on. And then the patient can see it for themselves and kind of add their value in terms of what they want to do out there. Seeing is believing.
How do you sterilize that in an in-office setting?
So it's disposable. So it comes from the shop. It's just a one and done. It's yours.
Oh.
And the price of that is coming down, so it's pretty reasonable to do.
Wow. I gotta get rid of my MRI machine then. I gotta sell my MRI machine. Shit.
Yeah, exactly. It's like, oh shit.
Oh my god.
Need 2 more.
Yeah, I know. We're opening one in Miami soon. So, did you were in the aviation wing as a medical doctor?
Yeah.
But you flew with them as well?
Correct. Every Thursday,
Wow.
I go up and go fly and do missions, and it's pretty interesting how they prepare. Excellence is like you can see that's alluded to in Top Gun. They don't, the movie's pretty sexy, but they don't show all the hard work that they do in the preparation and everything in terms of planning their flight out to the detailed minute, the communication they have as a team, the performance standards that they hold themselves up to as an organization. So everybody kind of grades each other's on their mission. They're really aware of where they're performing, what their expectations are. And even actually the camaraderie to work together as a cohesive unit is pretty impressive, which I tried to apply to medicine, because medicine, if you look, is in real dire straits in terms of organizational structure, which is a culture shock once I went through this organization with marine aviation, and then tried, even at Harvard, which is a pretty esteemed place, is we're having a hard time in terms of managing risk and working together as a team, which is kind of eye-opening.
Talking shit about Harvard here for any anti-Ivy Leaguers. We'll get into that.
Yeah, there's more on that to follow, right?
Let me, a lot of patients ask me this. A lot of clients in a car accident setting will ask me. They'll say, "Okay, I know something. My knee is messed up. I need something done with my knee. I did physical therapy, did nothing for me, strengthened it. It's no good." The patient knows that the therapy didn't work, so it's either something like an injection or some type of surgery, so they go see you. Let's say they need a scope, a knee scope. How long is an average knee scope? I know every patient's a little different, right? Some may be real quick, some may be very long. How much time on average is a knee scope? And then in terms of like risk of death, I think a lot of patients, I'm gonna die, and I'm like, you're not gonna die. It's a knee.
Yeah.
So tell me about the time and the risks involved with that.
So I always say as a surgeon, there's no problem so bad that surgery can't make worse, right?
Mm-hmm.
I can tell you horror stories of stuff that goes wrong at the hospital. It's never usually at the surgery center, but that's the real thing we have to risk mitigate. And the biggest challenge with that is actually the anesthesia, putting people to sleep. And there's different risk factors we can do. Frankly, I'm mostly doing under the knee arthroscopies under local anesthetic, and then giving them some sedation, or you can even do a spinal if you need to. And the spinal is what women get when they're having babies. Like nobody worries about getting an epidural, just because there's a real reason for it. They're not worried about dying because they just numb up your leg, and then you're very effective with it. So that's not very invasive, 2 small poke holes. And for me, a lot of that is just because you're going in there to figure out what's going wrong, to diagnose a problem, to quantify what exactly is. Because a lot of my patients, probably the same situation. Car accidents is tough to diagnose, right? There's a direct trauma that nobody really remembers because they're focusing on other things. Many times there's other injuries that's kind of been the focus. There's other significant pain generators, but it's been 3 months, they can't work. They're having pain going up and down stairs, and then you have an MRI that's reasonably helpful, but not fully comprehensive. And then there could be, an unhealthy joint, just the fact that it's not healthy, right? In terms of the chemicals are off. And then number 2, there might be actual biomechanical. They're not walking right. They're limping. They have to kind of retrain their brain. Or frankly, what I see is that they actually do have cartilage damage that needs to be addressed, right? And even if you go in and quantify the problem, and then number 2, if you do a simple clean out, do a chondroplasty. And so more often than not, I'll see a young, healthy patient with normal imaging. Everything says, hey, you're normal. And you get in there, there's a significant cartilage damage. And so, cartilage should be I think the number is 10 or 20 times smoother than ice, smoother than this table, right? And if you have a mechanical irritant, like a cartilage flap that's unstable and catches every time you move, that creates a mechanical disturbance, which creates inflammation, which creates swelling, which creates pain. So I'm like, we can always do, cortisone or PRP to help, the downstream effect, but you got to go upstream to fix a mechanical problem. And only to do that, you got to look inside and address it. And then oftentimes I quote a 75% success rate with a knee arthroscopy to get, treat the mechanical problem, whether it's inflammation in the joint causes swelling, or there's actually a cartilage issue that you can address and smooth it out, and then it should be sufficient. But then in the younger patients, sometimes I'll see a big, huge defect and say, listen, you need something long-term. We got to regrow the cartilage. We got to do a cartilage transplant. We got to give you some long-term options because, the knee scope may last you a couple of years, get you back, but it doesn't fill the cavity, right? And so then you got to go to the dentist and get address the cavity kind of thing.
Okay. And so with an average patient, blood pressure normal, diabetes, no diabetes, what are some things that people, I guess here's my question. So a lot of people are worried about dying after through a knee surgery, shoulder surgery. That's a real concern. I mean, I have 2 kids. If something happened to me, I'm worried about my family.
Yeah.
What is the risk of death in a surgery like a knee or shoulder? We're talking minimal here, right?
Yeah, oftentimes,
Okay.
if they're really worried about the risk of death, then we don't do the anesthetic, right? And then you just numb them up, they stay awake, because then the patient's still in control of their blood vessels, their vitals, right? They have their wits about them, and it's not painful, so you can do that. But also, too, then you talk to the anesthesiologist and it's like, listen, you're taking more risk driving to the surgery center than you are the actual procedure. We have 4 people here that are trained professionally. We have monitors on you. We have systems in place to make sure you're safe. And so, we take a look at that. You're generally pretty safe, right?
Yeah.
And so the same analogy of like getting on a plane. People are nervous, but you're actually much more likely to die in a car accident than you are in a plane. But the plane still creates anxiety because the plane's used to crash. And so it's kind of like the risk mitigation. You're actually treating anxiety, but if you objectively and critically look at it, you're generally very safe to have procedures. Certainly at a surgery center, it's something as minimally invasive as that.
Yeah, what I tell people is, I'm like, listen, these guys, they do surgery every week. They've done thousands of surgeries in their career. I said, you'll be fine. It's not his first rodeo.
Yeah.
Because people ask me, they say, well, I'm scared. And I'm like, I get that. But
reasonable human condition to feel.
Yeah. But what are you going to do with your knee? Like, you need to walk to get a job, to get paid, to feed your family. What are you going to do? And so thanks.
So one thing that's important to that, too, then we kind of reorient them away from the what ifs, but, what's likely in terms of, as a surgeon, I focus on pain reduction and functionality improvement. And so we have numbers that quantify it. It's like validated, objectifiable evidence that will track them. And so certainly in Boston, I would find my shoulder patients, we would do their tests before and after surgery, and I have 2 to 5 year results. And so usually my patients will start at surgery. They quantify their pain as moderate to severe. That's usually like a 5 or 6 out of 10, which is pretty significant. Like, at 8, you're in the hospital, right? So a 5 or 6 is not something to shy away with. That's a pretty severe injury. And then, we track them, and their pain goes up the first couple of days after surgery, but usually by, 6 weeks, 3 months, they're back to normal. I have what I call the high 5 group, and usually by 6 weeks, a lot of my patients can lift their arm without restrictions and are minimal pain requiring anti-inflammatories. And that's a pretty good deal, especially if you're at a 5 or 6 and like for 3-6 months you can't work. The bills are starting to pile up. Your significant other's mad because you can't sleep at night. You're tossing and turning. You're not good because you can't sleep. The reserves are kind of running out. And then you say, well, listen, like I know you're scared of like dying, but that's a bit irrational. It's always a risk. But at the same time, are you scared of living like this? If you look at our results, like that's pretty objective. Like it's a pretty reliable thing. Because I got to look my patients in the eye because we are assuming a little bit of risk, right? There could be a complication. No surgery is perfect, and also too, there's a lot of pain and suffering that goes with that. But this is a thing that I've kind of set up a program just to make sure everybody hits their numbers, right? And so, and also to get those numbers not without hard work, right? We have to work together as a team. Like, you have kids that you can't, throw them on the soccer field and just go score 100 goals. You got to kind of do a stepwise program to get them to perform at their level. And that's what we do with the shoulder and the knee outcomes is like we get the patients educated so they're a part of the team. We track them at the results. We take numbers and we're actually using our phone so that patients can connect to me directly or one of my team members just to make sure everything is going because small problems can quickly turn into big problems. And like, if you're worried about an infection, it's not hard for me to say, you're good, or like, oh boy, get in the office, let's get some medications on that before it becomes you get real sick on that. And so again, I would be scared of having surgery. I don't, I do it every day, but it's still a scary thing. But how do you mitigate that apprehension? And it's really through education and communication. And so we have this platform that's been pretty valuable to make sure my patients feel comfortable with us as a team. And then they, the whole way through from the beginning preparation for it, how much time off they're going to get, what are their expectations, and even like throughout the recovery, are they getting their therapist? What if their therapist says they're not getting better? And so we kind of track that and say, well, listen, you're right on track. So here's the numbers you're recording. Here's what the other 50 patients are recording. So so then you can kind of have solace of like, okay, I'm doing right where I need to be. Everything is good.
Awesome. This is all awesome stuff. So translate to modern day right now. You're with University Orthopedics. You taught at Harvard.
Correct.
You taught at Harvard. You work a lot on knees, shoulders, and hips. It's funny you mentioned hips and hip scopes in particular. Those were not that common 10 years ago, hip scopes, right?
Yeah, exactly. It's an evolving technology. And, we always say is like, what you train on is not what you're going to be doing. And it's really impressive to see how far we've come with all this technology.
Yeah. I met a guy who goes, yeah, I do hip scopes sometimes. And I'm like, what do you mean sometimes? How many have you done? He goes, honestly, I've only done about 10 of them, but I feel real comfortable doing it. So I think I could do it. If somebody needs it, I could do it. And it's fun because orthopedics is really like, you guys are like carpenters of the body.
Yeah.
You do a lot of, you got screwdrivers, you got chisels, you got hammers. I've seen some spine surgeries, knee surgery, shoulder surgery. It's like carpentry of the body. It's sick what you guys do. It's just like incredible. It's like instead of doing floors and walls, you're doing knees and shoulders. But hip scopes is not that common, but you've done a bunch of them, I'm guessing, or how does that work?
I was the go-to guy at one of the Harvard hospitals at Beth Israel, and so yeah, it's like it's not that easy, and you got to be able to recognize the pathology on that. But also too, what I do find is that we as medicine really haven't figured out how to really quantify unless you see it a lot, because most of my patients have been suffering for like 3 to 12 months, really have a hard time getting the right diagnosis. They've been treating for their back all the time, just not getting better. And then the doctor says, oh, well, I guess you're not going to get better. And then, a lot of my patients actually are coming to me from the internet because they're doing their own research. They're not accepting their situation, and they've kind of already made their own diagnosis. They just need to confirm it.
So you find a lot of people have low back pain. They're treated for low back pain. Turns out it's a hip?
All the time.
Wow.
Mm-hmm. Yeah, wow. And it's challenging because it's not an easy diagnosis. If you think about the low back, you have disc herniation, facets, the SI joint, trochanteric bursitis, labral tears, hip impingement. All those things are really difficult to tease out, and it kind of takes a multi-specialty group to kind of figure it out, which is what the nice plug for University Orthopedics is like. We have that option to kind of go back and forth and do some, opinion sharing and kind of get some information on it. Patients are in the dark a lot of times in terms of what's going on, and frankly, especially with their significant injuries, it's like numerous things going on, and it's like a juggle. How do you juggle all their stuff and even set the agenda to work together as an organization to optimize our condition? What procedure comes first? How do you treat it medically? Or like oftentimes I'll see patients and do the surgical evaluation and say surgery or no surgery, because like surgeons like to think or you don't, right? And so I can kind of screen what needs a quick surgery or is immediate urgency, or what can we manage non-operatively or even do procedures. And then we can send it to Dr. Garris, who's fantastic what he does. He spends his time getting into the details of it, and then if they fail conservative measures, I'm always there to kind of fix them in the end if they need to.
So cool. So let me ask you, when a patient gets let's just say, I'm just using a shoulder scope as an example.
Yeah.
What's the recovery time for them in terms of getting that arm out of a sling and back to mobility and functioning?
Yeah. So it's objectified now, and so usually, the arthroscopic procedure will be 30 minutes to an hour, right? Maybe it's a little bit longer, but the point is like that's like going to the dentist. It's not very long. It's a commitment for your day because you don't know exactly when you're doing it, and frankly, you're not in enough shape to go back to work after the surgery because of the anesthesia. And then usually we're pretty aggressive about the pain control afterwards. Now we're able to numb them up so they don't feel anything for about a day or two, and then we hit them hard with narcotics for about the first 3 days. But we got a pretty aggressive regimen with we'll throw ice on it, we'll put them in a sling, and we get them doing some basic exercises in the first day or so, and usually that takes care of the surgical pain. You're sore, but you're actually doing your thing. And then usually by the fall, I operate usually on a Thursday or Friday, which gives the patients, you take Thursday or Friday off, and you're off on the weekend, and then Monday or Tuesday, maybe go slow, check in on the office if you need to, or have a short week, and by then you should be back to your normal life, light duty, right? And usually I can get you back to your normal lifestyle within the first 1 to 2 weeks. I have some pretty aggressive home exercises because rather than going to a therapist once or twice a week, if you do the exercises at home at a regular schedule, I get great results. And then you're set up for therapy afterwards. So some of my patients will require narcotics for a week or two afterwards, but the vast majority are not doing it because we're actually recognizing narcotics aren't the best. There's other different modalities we can do for pain control. And then usually a lot of times my patients will set forward the goal of the high 5 at 6 weeks, where they have full functionality. They can kind of comb their hair, feed themselves, do what they need to do, and then their pain is minimal, where they take anti-inflammatories for a period of time. The challenge is for the laborers, right? The guys who use their arm for a living.
Construction guys is tough.
Yeah. And so usually we kind
of painters. That's,
totally.
Yeah.
Or, cleaners, planers, the people that, and then it's challenging because their employers don't really have this, like, if you didn't get hurt at work, it's not our problem. What are you going to do for that? And that's where we kind of work with them. And a lot of times with a therapist, we can optimize their planning where they're back to full range of motion. They just don't have the strength and endurance. So I usually characterize like week 6 and so on. It's like getting your strength back to near normalized. And so if you use your shoulder in terms of need it to really be strong and have endurance, that's a challenge. Usually by 12 weeks, I can get normalization. And then usually by 12 weeks, we start focusing on the sport-specific training. So, if your athlete's getting you throwing the ball, if you're a painter, getting the the ability to have endurance so you can last the whole day and those things. And usually by 6 months, I can kind of sign off on you unless you're a high-performance athlete. Mm-hmm. Or what we're doing now is just transitioning to remote modeling because after 12 weeks or so, you've avoided surgical complication. You're in a good position. You have prediction of long-term healing. You don't need to wait in my office for an hour and a half where you're missing work, not getting paid, just to say, how you doing, doc? Mm-hmm. And then they say, hey, you're good, go sign off. So that's why we track the outcomes. And so, if your outcome is off more than what's expected at that stage, then it kind of sets an alert and reaches out to the team. So we say, hey, what's going on, and problem solve.
Mm. Yeah, the biggest complaint I get from women after a car accident with shoulder pain is it's so difficult to put my bra on, or my shirt, and I'm just like, these are problems as men we don't ever think about, but
so the good news, McCormick's got an answer for that. Yeah, there's a special sports bra that you got to turn around, or a special bra that you have to turn around. Wow. But then I would usually refer that to one of the ladies in the organization for further.
They're giggling over here. Yeah, I never thought about that. Now I know.
Yeah, well, now you can know. Like, I'm passing on knowledge that's useful to you.
We'll call that the McCormick special.
Yeah, exactly. Changing your
Well, I had no idea that's actually pretty smart because I get that complaint all the time, and I'm like, I'm sorry, I don't know. So, shoulder injuries, how do those happen in car accidents? Can you explain that?
Great question. And so this is my synopsis. I don't necessarily think about it. When I look at it, I see so many patients after car accidents with the same mechanism, right? So there's got to be something to it. And I think honestly is the shoulder is kind of stuck in the middle, much like the knee. So if your hands are on the steering wheel, or even if you're a passenger and you try to reach to brace yourself, is that your head is a huge moment arm. So it slides your head, and that causes the neck injury. But at the same time, is that as your chest is moving forward, assuming you're hit from the rear end, or going to you're moving forward, you go to a stop, your body has inertia that carries it, right? Mm-hmm. And so this is going back to the long head of the biceps. The long head of the biceps is what I would consider as like a seatbelt on it, because when you get hit, you contract up, right? And so you create a force through your biceps, but at the same time, the inertia of your body is sending you through. So you're actually squeezing your muscle, but your body's inertia is pushing through against that tendon, which oftentimes causes the tear, right? And then so the biceps tears, and then right after that is the rotator cuff. And so there's actually 4 muscles of the rotator cuff. And what I oftentimes see is the muscle on top is the supraspinatus. That one is the most commonly damaged. And then there's one in the front called the subscapularis, and that I'm seeing torn in the younger guys, right? And so, if the one on top is a little bit weak as we get older, that's probably the first to go. But usually, the younger guys, especially as they're contracting pretty hard, they tear that muscle too.
Okay. Cool. And the supraspinatus is what allows you to go like this, right, with your arm?
Exactly. It allows you to lift your arm, right, especially into this area, which oftentimes you'll see that's really where it catches after. And shoulder injuries are very common. It's actually one of the most common reasons people go to the doctor. But it's that mechanism of that direct hit really kind of creates a bit of a perfect storm for them. And what I oftentimes see is that the neck and back gets most of the tension because that's very painful. But at the same time, then we have to kind of realize to lift your arm, and it's like, oh, is that my neck or is it my shoulder? And that's where oftentimes Dr. Regaris and the guys at UOC kind of work pretty well to say, oh, this might be a shoulder issue versus a neck, and kind of how do we work them out together.
Yeah. How do you differentiate a shoulder from a neck? Because I have a lot of people, they say I have pain in my neck that transfers into my shoulder. And so, you have your traps, which are connected in that area. And then you can get MRIs for herniated discs, see if there's disc injuries or even facet pain. But how do you differentiate that? Because I think a lot of doctors, let me get you a neck MRI. Very rarely do they say a neck and a shoulder, right? Is that
exactly? And that's literally like the $1 million question. If I had the perfect solution for that, then I wouldn't have to sit in front of this chair. We'd be out, celebrating. But at the same time, that's where the multi-specialty, frankly, for me, the key thing is I hone in on the biceps. And so then I'll use the exam. And oftentimes I'll have the patient come in where your neck may hurt, but it radiates. But if I push on your shoulder and it hurts, ipso facto, it's some pain is coming from your shoulder, right? And then oftentimes too, if it's one shoulder, then I'll push in that same spot on the right other shoulder, and if that doesn't hurt, then you have a contralateral comparison to say, pain is pathology, right? Like, we're not in pain normally. We don't go to doctors because we're not in pain. We're going because of pain. We're trying to figure out what's the root of that problem. So if it hurts to touch that, then we've kind of localized our situation. And then you say, well, how much pain is coming from that? Then oftentimes I'll do a cortisone shot with lidocaine to numb up the shoulder so I can compare shoulder versus neck in pain, right?
Okay.
And to do lidocaine throughout all the neck is dangerous and difficult. So the shoulder's simple and easy to do. So I have it a little bit easy to kind of, cherry pick how much pain is coming from your shoulder versus the physical examination and the diagnostic injection.
What kind of hardware would you put in a shoulder? I know, like we talked a lot about scopes. What are some options for people in a car accident, hardware-wise?
Yeah. And so there's a couple things. One, it could be just straight up inflammation. There's damage to the tissue, and if we just go in and physically remove it because it's not, it's significant enough that it's in such a large quantity, it's causing pain. And number two, it could be scar tissue, right? You get in an accident, trauma, even if you're playing sports, you fall, hurt your shoulder. If there's still pain after a period of time, then it's not unreasonable to see scar tissue. I see that very commonly, and guess what? Scar tissue doesn't show up on MRI, right? So it's based on physical examination. There's some things we can kind of do in the operating or in the office to quantify scar tissue versus tear, whatnot. But also too, the challenge is what I will see is that the rotator cuff may be in pretty good shape, but more torn than not, or not torn, and so the MRI doesn't answer that. So you have to go in there and kind of see. And so I give the analogy, if you had a rope, and the rope is kind of like what you're using to pull your arm, and if it's partially torn, say 50%, all that force is going through the half of the tendon, so the pain goes up because it's being overloaded and likely to fail. And so there are some things that are new technology where you can put a patch on to heal the rotator cuff. Many times we'll actually put a stitch in to reattach the tendon to the bone, which is just a suture, and now we have they're considered anchors, but they're like screws that are made up of the same composition of bone. So it actually makes it pretty well, because then your cells kind of grow into that, and then they'll grow into the tendon and create healing. So that's pretty unique.
Cool. So, Doc, thanks for joining us. What locations, if somebody wanted to see you, what locations do you practice out of at University Ortho?
So, Abe, I'm a very busy guy, and I actually just this week did my last day of working at Harvard, which has actually put a tear in my eye, but allows me to be in Florida much more often. So if you do the numbers, I cover 7 offices throughout Florida.
Wow.
So we're in Broward, we're in Broward, Palm Beach County, and Port St. Lucie, Kissimmee, Orlando, and Fort Myers.
Fort Myers, there you go. I wonder why you moved down here, but it's the weather.
More than the weather.
It's the weather, right? Cool.
Yeah.
So thanks, Doc. Appreciate you being on the podcast, and thanks for all the input you got.